And importantly, they have to happen during the developmental period. That's why we call them developmental disabilities, and that means up to about age 18, so that whole developmental period. So interestingly, if you have a young adult, let's say, who's 23, who never had any developmental problems early on, and then has a car accident, let's say, and ends up with impairments in functioning, that person would not have a developmental disability. That person might have a traumatic brain injury, etc. But let's say that same person was 16 years old in the developmental period, had that same accident, and ended up with difficulties in function, that person would have a developmental disability. So it's a bit of an artificial distinction there. And about 1 in 6 children in the US has a developmental disability, which is an amazingly high number if you think about that. But developmental disabilities also encompass a lot of different things. So something like attention deficit disorder, or ADHD, is so common. That's what really is driving a lot of that number. But then there are less common conditions like intellectual disability, autism, CP, etc. And so all of these come under that umbrella of developmental disabilities. One thing I didn't mention is that, we now are sort of shifting from the terminology of developmental disabilities to neurodevelopmental disorders. That's in the last several years. It means the same thing, essentially. We're talking about the neuro was put in there to recognize that these are brain-based conditions. These are medical brain conditions. We also refer to these as intellectual and developmental disabilities. So the naming is a bit of a moving target. So one of the very confusing things that continues to happen when we talk about developmental disabilities is now we have lots of kids getting different genetic diagnoses, because genetic diagnostic workups are part of the evaluation of a lot of children who present with developmental delays and other problems. And so they may get genetic diagnoses because we have pretty powerful tools right now like whole exome sequencing and microarray analysis that can identify lots of genetic disorders. So, for example, there's a lot of confusion out there. Here we have 3 kids, let's say, in a developmental preschool. All of them have been identified as having developmental delay. So their development is a certain percentage below what's expected, and then they qualify for school services. All of them have been diagnosed as well, in this picture, with an autism spectrum disorder. So they have behavioral differences that can be categorized in that way. And when you look at them, what we realize is that all 3 of them have the same developmental diagnoses, but they have 3 different genetic diagnoses. So the little girl in the middle has DUP15, the boy on the left has Fragile X syndrome, and the little girl on the right has the 22q11.2 deletion syndrome. From a genetic counselor standpoint, these are 3 completely unrelated disorders, and yet they present with developmental delay and an autism spectrum disorder. So you can imagine the confusion in a preschool classroom where all of the kids have developmental delay and autism, let's say, and the teachers are thinking, yeah, all the kids in my class have the same diagnoses, and yet they come in with different genetic diagnoses. The same is true in school age. These are 3 kids, let's say, in a learning support classroom, and all have been diagnosed with an intellectual disability, what used to be called mental retardation up until about a decade ago, and now we call ID, or intellectual disability, in the United States. And all of them, again, have been diagnosed with an autism spectrum disorder based on a pattern of behavior that they present. And all of them have been diagnosed also with an anxiety disorder. They're probably anxious because they have way too many diagnoses going on, but diagnoses get made to try to drive treatment or to figure out like what's going on with these symptoms and how do we address this. So an anxiety disorder diagnosis in all likelihood is made so that a medication can be prescribed, because when somebody goes to a psychiatrist, for example, or a neurologist to try to get a medication for some sort of behavioral problem, you have to get a diagnosis in order to justify getting that medication. So as a child gets older, the number of diagnoses often tends to rack up and get higher and higher. In fact, I've worked with many adults in my career, and many adults will have 7, 8, 9 different developmental diagnoses over the years, depending on what they present with and what we're trying to treat. So as you can imagine, it creates a lot of confusion, especially now with genetics, when genetic testing is done, and what we find is this little girl on the right has Smith-Magenis syndrome, this child has Fragile X, and this boy has the 22q11.2 deletion syndrome. Again, 3 totally unrelated genetic disorders on different chromosomes that have absolutely nothing to do with each other. So what's going on here? Well, the bottom line is when we talk about genetic diagnoses like Dup15, we're talking about etiology, and etiology means the underlying cause. So what is the underlying reason for the differences in brain function that result in the behaviors that we see on the outside? And developmental disabilities are symptoms for which there are literally hundreds to thousands of different underlying causes, most of them now known to be genetic and different genetic changes. So genetic and medical factors play a role in causing most developmental disorders. That's well established now. In fact, if you take all children who have an intellectual disability and you apply current types of genetic testing, almost half the time we can identify a specific underlying cause. And there are thousands of different underlying causes, believe it or not. Dup15q is one that we've known about for a number of decades because it was something we could pick up even with older technology. So a lot of the causes being identified today are newer ones, and there's very, very little known about them except that they seem to cause changes in brain function. So for Dup15q, we're in much better shape. We have a longer history of knowing about this condition. But if there's nothing else that I want you to take home out of this talk, it's just this sort of second bullet here, that these symptom diagnoses like intellectual disability, global developmental delay, autism, they're all symptom diagnoses. There's nothing wrong with that, but you need to realize that they reflect what you're seeing on the outside, their symptoms, and the genetic diagnosis reflects something very different. It reflects an underlying cause. It's what's driving these symptoms. And so you can have symptom diagnoses and etiological or genetic diagnosis all at the same time. So a developmental diagnosis like autism tells you what you're seeing on the outside, and an etiological diagnosis like Dup15q, for example, tells you why, what's the underpinning. And the bridge between these behavioral or developmental diagnoses and the cause diagnoses is still very incomplete. And you know, you can come to this conference and hear a lot about Dup15, and lots of people know about this condition here, and then you go back to your child's school and you know, they just don't make that connection. They don't know how to fit the genetic diagnosis into the diagnoses they're used to, which are primarily the developmental diagnoses. Why do we care about causes or etiology? Well, that's speaking to the choir here because, of course, you're here and you care about the cause, but there are a number of really important reasons we should be caring about cause. One is for genetic counseling. You know, by and large, if you have a child who has particularly the isodicentric form of Dup15q, which is what most of the families have, it occurs out of the blue. The chance of that happening again in another child or in a sibling's child in the future is no greater than for any other family. And that's very reassuring. And if you didn't know the underlying cause, you wouldn't know that, because there are other genetic disorders like Fragile X where there's a 50-50 chance that a sibling may have inherited something, right? So for Dup15, we know the etiology. We know it generally does not recur within families, and so that's important information. Do know families naturally, when you have a child with special needs, kind of go back, and particularly moms, going back over the pregnancy. What did I do? Did I cause this? How did this happen? And, you know, have a lot of guilt about what's going on, especially when they don't know the underlying cause. And so that's why we have all the misinformation and nonsense, frankly, around vaccines causing autism and other things that are just frankly not true. And I do understand part of that is because people don't have answers, and so they're sort of latching on to whatever they can find. When you have a genetic diagnosis like Dup15q, we do know that this causes, at a fundamental level, changes in the way the brain functions, and that can result in behaviors that we call autism. So it can relieve a lot of those misconceptions and the guilt that you feel. We have no control over our genes. Certainly when a child's conceived with a DUP15Q, there's no control there. So at first you may feel like, oh gosh, how did this happen? But it's something that was outside of your responsibility. There was nothing you ate during pregnancy, nothing that you did. You didn't party too hard in college. It was nothing you did when you raised that child early on. This is something that just naturally is known to happen. It's been happening since, babies were conceived. These are things that just happen out of the blue, and there's no causation. So that guilt can go away. For families that don't really have an etiological diagnosis, that guilt often can just last. They're always wondering, was it because of this or that? You've heard at this conference how, we can learn a little bit about the medical needs of kids when you know an etiological diagnosis, such as epilepsy in kids who have the DUP15Q syndrome, etc. And we're really starting to understand a little bit more about behavior and learning styles. And in DUP15, we do know that there's a very high chance that a child will manifest some autistic behaviors and get an autism diagnosis. So knowing that from a very young age might help to maximize getting some resources around therapy to help engage that child, etc. And then, of course, there are diagnosis-specific organizations like the Alliance, which are specifically for our etiology, but there are hundreds and hundreds of them for all different genetic disorders. This happens to be one of the most well-established. It's been around for decades. And then, finally, targeted research, which you'll hear more about even today and tomorrow at the conference. We're not there yet, but there are researchers diligently working on trying to understand what is it about having extra copies of those genes that causes the brain to function in a way that means they have epilepsy, or the child isn't engaged, or the child is not learning as quickly as possible. And that's really many, many steps ahead of research that's just saying, we're going to do autism research. You have 1,000 kids with autism, you have 1,000 different etiologies, potentially, for why they have autism. That's not a very good starting point for research. Finding an etiology or the underlying cause is a much more focused research that we know that the autism in DUP15 is related to this particular underpinning, so let our research start from that point. So neurodevelopmental disorders or developmental disabilities have been of interest to different groups and professionals for many, many decades. So psychiatry's been interested in developmental disorders just because they involve brain function and differences in the way people manifest different psychiatric features like anxiety, maybe depression, maybe psychosis, where they're sort of imagining things that aren't real. So psychiatry's been very interested in neurodevelopmental disorders. Psychology has also been interested, and particularly from the aspect of behavior and also from school functioning and how people function, autism, behavior, etc. And genetics has been interested as well, and genetics' interest in neurodevelopmental disorders has always been from the standpoint of etiology, what's causing this. And unfortunately, these three groups up until recently really didn't interact with each other. So they all came up with their own diagnostic systems, their ways of talking about these things, and really weren't cross-fertilizing at all until very recently. And what happens in the school setting is that often these genetic diagnoses, or DUP15Q and the others, are considered irrelevant. You'll come back from this conference and you have a stack of materials to hand to your child's teacher, and then they might say, oh, well, let's send that down to the nurse because it doesn't mean anything for us here in the classroom. And instead, what they're relying on are the educational and the psychiatric diagnoses that are part of the school system. So what are those psychiatric diagnoses that we're talking about? Well, you may not be thinking about autism as a psychiatric diagnosis, but it actually is. In fact, ADHD, autism, bipolar disorder, different mood problems, depression, and there's even a definition for intellectual disability in the psychiatric manual. These are all psychiatric diagnoses. So what is a psychiatric diagnosis? It's based on observed patterns of human behavior. That's all a psychiatric diagnosis is. And they're diagnosed using criteria that are in a psychiatric manual called the DSM, or the Diagnostic and Statistical Manual of Mental Health Disorders. And basically, a psychiatric diagnosis is made when somebody presents with behaviors that are consistent with one of the diagnoses that are described in the book. And so if a child is running around the room at age 10 and can't sit still and can't focus, there are criteria for attention deficit hyperactivity disorder, and say, oh, well, that child must have ADHD. There's no blood test for ADHD. It's based on, do you have the symptoms that go along with this? So they're not diagnosed with laboratory tests. And this is important because I still get calls from families saying, I think my child might have autism. Is there a blood test or an MRI of the brain we can do to check for this? And the answer is no. The diagnosis of autism is made completely on the basis of what that child is showing on the outside. What are the behaviors? What is the history, etc. Now, there's nothing wrong with that. These behavioral diagnoses help us group people into different categories and diagnoses, but you need to keep in mind that there's no focus on etiology here. It's just what are we showing on the outside. And there's no brain scan that's going to say, oh, this child's going to have autism or this adult's going to have schizophrenia. It's all just based on the clinical picture, what you show. And so in the school systems and in adult services, really a lot of our eligibility criteria are based on the psychiatric diagnostic system. So autism is defined there, obsessive compulsive disorder, ODD, anxiety, bipolar, ADHD, etc. As I said, there's even a definition in the psychiatric manual for an intellectual disability. And because of that, the services are driven by these diagnoses, not by the genetic diagnosis. So families will sometimes say, well, my child just got diagnosed with Duke 15. He had a diagnosis of autism. Should we get rid of the autism diagnosis? And I'm like, no. The autism diagnosis is what's going to help you get services, not the Duke 15 diagnosis. They're two different things. The Duke 15 is the underlying reason. The autism is how it's showing on the outside. But it is confusing because let's say we have a child who has developmental delay and then gets diagnosed early on with Duke 15, and as that child develops, has some of the behavioral features of autism, gets diagnosed with autism, and then seems to have some attentional issues, etc., and maybe a medication is being considered, gets a diagnosis of ADHD. Maybe as they reach school age, they have an IQ under 70 and are having significant learning disabilities, so we'll get diagnosed with ID, and then later on, maybe diagnosed with anxiety again because they just have too many diagnoses. But the fact is, you could look at this diagnostic alphabet soup, and teachers and families often will conclude, oh my goodness, how did my child get 6 different things? And the fact is, your child doesn't have 6 different things. Your child has one thing. Your child has Duke 15q syndrome, which resulted in changes in the way the brain functions that on the outside give you these other symptoms, right? So a single cause and multiple symptoms. And sometimes it's just important to kind of explain to school districts and others about that concept because they don't quite understand. And there are things with certain genetic syndromes that we can learn about behaviors and interventions for the symptoms based on the genetic diagnosis. And for Duke 15 right now, best practices to follow the best treatments for autism and developmental delay. But at some point in the future, there could well be some very targeted types of treatments that might be related to this particular cause. So that's part of what we're all working for in research. Okay, we got a little bit of a late start, but I'm going to skip over a couple of things. I do want to talk about intellectual disability because it's a diagnosis that I think particularly for parents of young children just diagnosed, they worry about this diagnosis, what does this mean, etc. So intellectual disability is the condition that formerly used to be called mental retardation. And that terminology fell out of favor because socially it became a very derogatory, negative thing, and then they replaced it federally and all the laws, etc., in 2009 with ID, or intellectual disability. There were other terminologies that fell out of favor before mental retardation, and so it's a moving target. I never heard of such a diagnosis that has to be a continually moving target, primarily because of just the way society takes those words and turns them into something very negative. So my guess is that, give it 20 years and ID, somebody will figure out some terrible way to make ID sound awful, and then it'll be changed to something else. But what is ID? Well, the important thing to understand about it is that it's defined, and there are a number of different definitions. This is the one from the psychiatric manual, but it's really not a biological idea. It's something that we've defined artificially as a society to figure out who are the 1 to 2% of our population in society who are going to need extra supports. That's basically why we even have a definition for ID. So by its nature, it's artificial because we came up with it. There's no biological thing that says, oops, if you have this protein in your blood, you have ID, and if you don't have ID. So the criteria are, first of all, you have to have deficits in the way you learn and your intellectual functioning, and that's measured by an IQ test. And currently the cutoff in IQ is 70 or below. And it's not enough to just say you have an IQ of 70 or below. You have to have impairments in adaptive functioning, or the way that you can navigate your environment. And those include issues with communication, social skills, personal independence, functioning at work and school, etc. The third criterion is that it has to happen during the developmental period, right? So intellectual disability is a developmental problem, so it has to happen up to age 18, and as I said at the beginning of the lecture, it's very artificial because you could have somebody in his 20s who was functioning fine, who got into a car wreck and ended up meeting all these criteria, but he wouldn't have ID, he would have traumatic brain injury, yet you might have somebody with the same level of functioning, and if it happened before 18, that person would have ID. So it is artificial, but we have reasons for this diagnosis. So I just want to call that to your attention because I think there's tremendous worry sometimes for preschool parents, early on it's called global developmental delay, and it's kind of a kinder, gentler thing. There's always that delay, maybe they'll catch up, and kids are moving in the right direction, they're gaining skills. But then it's really a harsh reality sometimes when some kids end up having a diagnosis of ID, usually around age 5, entering regular school, they're going to get a more confirmed diagnosis. It's really not appropriate to be referring to an adult with developmental delay. If they haven't caught up by adulthood, they're not catching up, So it's really around that school age that it turns into something more concrete. And it's something that can open the doors to services, and it doesn't mean your child has changed overnight. They started with global developmental delay, the next day we're diagnosed with ID. It's still your child, the same functioning. And it's not that there's something magical that has happened that has really changed here. It's really just confirming what we've seen all along, but now we're going to put a very specific designation on it. And I mentioned that it's artificial in that, if you look at the IQ curve of like all the people in the United States, the average IQ in the States and elsewhere, the IQ tests are made so that the average is 100. And there's nothing magic about 100. The tests are made so that the average IQ is going to be 100. If the people get smarter, they have to make the tests harder so that the average will be 100, right? So this is a very artificial number, And ID, the cutoff is 30 points below that average. So the cutoff is 7, and that encompasses about 1 to 2% of the population. There's also another artificial designation on the other side for gifted, at least in the US, where if you're 30 points above the average, your child could be designated as gifted. So I think the same sort of artificiality applies, and you have those parents who are so puffed up because their child is in the gifted program, because their child has the IQ over 130. You have the poor parents who have the child with IQ of 127 who are all, downcast. Oh my gosh, it is an artificial dividing line. And it is because we said so, because that's how we make it. And that's all it is. It's not a biological definer. So in conclusion, there's a lot of diagnostic confusion out there about different diagnoses that get used, and we know that psychiatric, behavioral, and learning symptoms are found in association with many genetic disorders. Certainly, DUP15Q is not the only one. There are hundreds and hundreds of genetic disorders with developmental issues, and it's important to know the difference between causes versus symptoms, and that's why the genetic etiology is still important, because it explains the underpinning, and we are doing a lot of research on trying to understand those underlying causes, which in the end is going to be more valuable than just trying to treat symptoms on the outside. Educational and behavioral diagnoses are the ones at the moment that are really driving eligibility and services within school settings and even adult services. So it's really important to understand that and not say, well, I'm only going to focus on DUP15. Well, you need to understand how that's manifesting and what really are the needs of the individual, because just look around this conference. There's such variability from one child to the next, from one adult to the next. If you just went on the DUP15Q diagnosis, you wouldn't be able to really pinpoint what are the needs of each individual child. So individuals with DUP15Q meet criteria for one or more behavioral and educational diagnoses, and it's quite variable, and you want to use those diagnoses for everything they're worth. I mean, I don't mean piling on diagnoses that don't fit, but if it fits your child and your child has diagnosis of autism, then embrace that and look for resources within the broader autism community, realizing that the DUP15 is what's causing the autism, but you can also benefit from knowing the symptoms. Schools and teachers are unlikely to be familiar with DUP15Q, and that's okay. Come on, are they really there? This is not part of their training to know all the thousands of different genetic etiologies. And I have families yet who say, well, we're going to move because our school just never heard of this syndrome. Well, they're not going to know it. And actually, it doesn't mean they can't provide great services. If they're providing great services, and you as parents would have an intuitive sense, boy, my child is really learning and moving, and these goals are really in sync with what my child needs, then that's great. They can provide excellent services. An open mind and willingness to learn about the genetic syndrome and a creative approach are what you really need. So don't try to be moving around to different school systems because you heard that there are 3 kids with DUP15 in this one large district and they know about it. Because you could get the worst teacher in the district who says, I know DUP15, and they really don't do a very good job with your child. So try to chill out a little bit. If you're working and you have a gut sense that your school is doing right by your child, it doesn't really matter whether they can pronounce DUP15Q. Let's hope that you can bring them some information and they're interested, but what's really at the moment going to help your child best is to really have a good sense of what your child's needs are functionally and on the outside. So work with those diagnoses your child has. I want to acknowledge my many colleagues in central Pennsylvania where we have a wonderful DUP15Q clinic, and thank you very much. I know we got a bit of a late start, so I will be around out there for any questions for probably until about 10:30. So if anybody have questions, I'll be happy to take them there. Thanks.